Hi, everyone. Welcome back to the clinical track. Our next lecture is going to be with Daniel Epshtein. Dan is a very, very good friend of mine and colleague. He was a couple years behind me at SUNY Optometry. He currently practices in the ophthalmology department at Mount Sinai. He's also an adjunct professor at SUNY, so I get to see him a lot. Very, very excited for his lecture today, giving us some updates about new developments in anti-VEGF therapy.
Hello, and welcome to the session on new developments in anti-VEGF therapy. My name is Dan Epshtein. I'm an assistant professor within the ophthalmology department of Mount Sinai Morningside Hospital here in New York City. I do want to take just a quick second to thank the Eyes On Education Committee for inviting me here to speak on this topic, and thank you all for joining us here as well. Really do appreciate your attention. Hopefully, you are as excited about the new treatments in the anti-VEGF space as I am. I think it's a really exciting time because there's a whole lot of new therapies that will become available within a few years. And with that, this is my financial disclosure, and this is our agenda for today. We're going to go through a very brief introduction to anti-VEGF therapy. We'll go over two studies of Protocol W and Panorama studies, and then we'll start talking about some of these new anti-VEGF therapies. These are our current intravitreal anti-VEGF therapies. The first three, bevacizumab, ranibizumab, and aflibercept, are the ones that are used most often. These are the ones that we're most familiar with, but brolucizumab is kind of a new kid on the block, which we'll speak about as well. Talking about dosage of those three common ones, it kind of depends on which disease we're talking about. Both ranibizumab and aflibercept have been FDA approved for neovascular AMD, proliferative diabetic retinopathy, and diabetic macular edema, and then retinal vein occlusions with macular edema. For ranibizumab, the injection dosage is once every 4 weeks, but with aflibercept, after a loading dose, the injection is done every 8 weeks. Again, that does differ depending on whether you look at neovascular AMD or the PDR DME group. For retinal vein occlusions, it's once every 4 weeks. And when we're talking about bevacizumab, it's used off-label, but it's essentially the same thing as ranibizumab in both efficacy and the dosing schedule. So what this means for patients is that if they're on aflibercept, they're basically getting less injections per year, which is great for them. They don't have to come into the office as often. And it's also great for doctors because then they can spend time on other patients as well. These three medications, I think we're all used to co-managing with the retinal specialist. I think we've kind of started thinking that these are almost risk-free injections, meaning the rate of adverse events is extremely low. In fact, when you look at these large meta-analyses, the risk of endophthalmitis is less than 0.1% usually. And this is looking at thousands of injections over thousands of patients. As I'm talking about some of these new anti-VEGF therapies, these are kind of the 3 points I want you to think of when you're comparing them. One is efficacy in preventing vision loss or improving vision, meaning are they better than our current treatments at improving vision or preventing further vision loss? And what is the durability of treatment, meaning how often are patients getting injected? Are they once a month, once every 2 months, every 3, 4, 6 months? Ideally, the less injections you do, the better it is for patients and for doctors. And then you have to look at the safety profiles. So our current treatments are, like I said, are very safe. We often don't really think about the safety profile. But with some of these new anti-VEGF therapies, there are higher risks. So we really do have to think about the safety profile a little bit more often. And when we look at our current and intravitreal anti-VEGF therapies, aflibercept is kind of like the gold standard. It works very well, in some cases better than ranibizumab and bevacizumab in terms of visual outcomes. It's dosed less often, but it's just as safe as the other two. So looking forward, a lot of medications are being compared to aflibercept because that's kind of our current gold standard. Now let's go into these two studies. Protocol W enrolled 399 eyes of 328 patients with moderate to severe NPDR, and none of them had central involved diabetic macular edema. Half of the patients received aflibercept injections, and half of them received sham injections over a 2-year period. The important thing to note was that rescue aflibercept, meaning aflibercept injections required for patients based on disease state, were given as necessary. So if anyone developed central involved diabetic macular edema or PDR, they were offered aflibercept. In those cases, patients weren't just allowed to lose vision just so we can study them. And what we found out is that over a 2-year period, the probability of developing center-involved diabetic macular edema or PDR was 16% in the aflibercept group versus 43% in the sham group. And then we could split that up based on just the PDR developing patients and the center-involved diabetic macular edema developing patients. But basically, it's a 3-fold decreased risk of developing visual issues or PDR with prophylactic treatment of aflibercept. But another main thing that came out of the study was that the mean change in visual acuity at the end of the 2-year period was the same between the two groups, meaning there was no statistically significant or clinically significant change in visual acuity, whether you treated prophylactically or you treated patients as they developed disease. Panorama was a similar study. This had 402 patients with moderate to severe NPDR without center-involved diabetic macular edema. Here they had 3 groups. One group was getting aflibercept on every 4-month dosing schedule. The other one was receiving on every 2-month dosing schedule, and that was after an initial loading dose period. And the third group received sham treatment. Again, either group was eligible for rescue aflibercept if necessary, based on worsening disease. And these 3 charts summarize some of the main points of these studies. These orange bar graphs are the sham group. These grayish bars are the aflibercept every 16 weeks group. And then the blue bars are the aflibercept every 8 weeks group. And what this represents is improvement of diabetic retinopathy severity scale scores. So very few patients improved in terms of their diabetic retinopathy severity in the sham group, but significant amounts of patients improved in both aflibercept groups. At 24, 52, and 100 weeks, there was a pretty big difference between the sham and the treated groups. Here in the bottom left, we have, again, the sham group, the Q16 weeks treated group, and the Q8 weeks treated group. And this summarizes the the proportion of eyes developing vision-threatening complications, meaning PDR, or center-involved diabetic macular edema. And you can see that a significantly larger proportion of patients developed issues in the sham group versus the treated group. And then if we look at the cumulative incidence of vision-threatening complications, up here in the darker curve is the sham group, and then we have the orange and the gray curves, which are the treated groups. And similar to Protocol W, there was a 3-fold decreased risk of developing these vision-threatening complications. And again, similar to Protocol W, the visual acuity at week 100, on average, was the same between all 3 groups. So what do these 2 studies tell us? That prophylactic treatment of severe NPDR with aflibercept will improve NPDR, lowers the risk of developing vision-threatening complications or worsening NPDR. But it also told us that whether you treat prophylactically or you treat as disease develops, at the 2-year mark, you're going to end up with the same visual acuity. But there's a caveat to that. This was a research study with a research protocol. So all patients were monitored very carefully and treatment was initiated very quickly. This is usually not what happens in the real world. In the real world, patients get lost to follow-up. They don't go to the retina specialist when we refer them. Sometimes they refuse treatment. Sometimes they get lost to follow-up as they're being treated. So likely what would happen is, this is the real world, visual acuity would be worse in the sham group than would be in the treated group. But again, that's more so my opinion, but I think a lot of people out there would agree as well. The other thing that you have to keep in mind is that when we look at research studies, when we look at research data, we're talking about averages. We're not talking about the individual patient. So the journey of the individual patient might look a little bit different. Yes, at a 2-year mark, their vision might be great, but maybe for 3 months, 6 months, even a year, their vision might be very poor. So poor that maybe they're not able to drive, maybe they're not able to work, maybe they become dependent on a caretaker for a short period of time or even a long period of time. And that is time that the patient is suffering. So yes, we might be able to remediate their vision by the 2-year mark, but 2 years is a long time. So the way I think about it, about these two studies, is that if we treat patients prophylactically, it's probably going to be those high-risk patients, the ones who have a very high A1C, who have an A1C that's trending up instead of trending down. Patients that you think that will get lost to follow-up. Those might be the patients worth treating prophylactically because they might possibly have better outcomes. Protocol W study is being sort of done until year 4, so we will have more long-term data. And when we have the more long-term data, maybe there will be differences between the two groups, and that will help dictate how we treat some of our patients. Moving on to Brolucizumab, this is a molecule that was approved by the FDA for neovascular AMD in 2019. The 2 FDA studies were the Hawk and the Harrier studies, which compared Brolucizumab versus FlipRecept. The Brolucizumab group had 1 injection every 4 weeks times 3, then 1 injection every 8 to 12 weeks. The patients receiving an 8-week schedule remain on an 8-week schedule for the whole study. But the patients that were on a 12-week schedule, they could be switched to an 8-week schedule depending on disease state. A FlipRecept group was a little bit more simple. They received a loading dose of 1 injection every 4 weeks times 3, and then 1 injection every 8 weeks after that. And what the study found was that Brolucizumab was non-inferior in terms of visual outcomes at 96 weeks in comparison to FlipRecept. And the medication was approved. Then, as the medication was used in regular clinics around the United States, we found that there was a relatively high rate of intraocular inflammation. So much so that in 2020, the FDA updated the safety label, stating that 4.6% of patients developed this intraocular inflammation. Quickly comparing FlipRecept with Brolucizumab, Brolucizumab is only indicated for neovascular AMD at this time, whereas FlipRecept has indications for these 3 disease states. But you can see that Brolucizumab, you can extend treatment out to 12 weeks, whereas FlipRecept is only out to 8 weeks after the initial loading dose. And these are the Hawk and the Harrier studies. And here we're looking at change in visual acuity. The green curve is going to be our Brolucizumab group, and the gray curve is going to be our FlipRecept group. And you can see that very similar visual outcomes throughout the Hawk study. But when we look at week 48, 56% of patients were on a Q12-week schedule, and at week 96, 45% of those patients were on a Q12-week schedule. Harrier study, similar. Patients ended up at a similar visual acuity at week 96, but again, at week 48, about half those patients were on Q12, and at week 96, about 40% of those patients in the Brolucizumab group were on a Q12 schedule. Talking about anatomical outcomes, meaning our OCT outcomes, how much thinner did the retina get, how much drier did it get, we can see that brolucizumab group is essentially better at all the time points in both the Hawk and the Harrier study. So even though vision ended up being the same at the end of each trial, the brolucizumab group actually had a thinner, more dry macula based on OCT. And then we have to look at safety. So intraocular inflammation, we already talked about that, higher in the brolucizumab group than the control aflibercept group, but also there was a 1% risk of endophthalmitis, blindness, retinal artery occlusion, and retinal detachment, which is much lower in the control group. So this makes you start thinking that, hey, the safety profile is a little bit different for this new medication. And the scariest thing was really that intraocular inflammation. Yes, some patients just had some vitreal cells, some AC cells, but the scariest patients were the ones that developed this hemorrhagic vasculitis. Sometimes they also had retinal arterial occlusive disease as well. So on the top left is a patient treated with brolucizumab. This is kind of early on in the course. You can see peripherally there are some hemorrhages and vasculitis. And then this worsens later on into this massive hemorrhagic vasculitis response here. And you can see there's also vitritis, which is masking some of the posterior segment. But basically the whole retina is affected. So patients might go from maybe 20/30, 20/40 from neovascular AMD, and they might end up being hand motion 2400. Now, yes, that might be temporary, but in some patients, it was not. This is another patient, again, early on in the course in the top left. Yeah, you see some peripheral vascular sheathing. That's the vasculitis early on. And then this progresses into a full-blown hemorrhagic vasculitis response here in the bottom right. There's a significant vitritis, so much so that you can't really see any details on the fundus. All that you really see is the hemorrhagic response of those large blood vessels. So this is, again, pretty scary, and it was especially scary because we didn't really ever expect any type of significant adverse reaction such as this from anti-VEGF therapy. And we didn't really know how to treat it in the beginning. Now we've gotten a little bit better. We know these patients respond pretty well to steroids, whether it's intravitreal, topical, or sometimes oral. Now at least we know how to treat these patients. We know to monitor these patients quite often in the earlier period. Hopefully the rate of this intraocular inflammation, at least vision loss of this intraocular inflammation, is decreasing as well. Aflibercept has been FDA approved for a while, but now there's a study looking at a high dose aflibercept. There's a phase 2 proof of concept safety trial, which is comparing the 2 milligram aflibercept standard dose versus 8 milligram aflibercept high dose. So this is a new treatment coming out, hopefully. There are 106 patients, 53 in each arm. They all had neovascular AMD. And all patients received injection every month times 3 and then extended as per the clinician investigator. At week 16, 43% of the 8 milligram group had no retinal fluid, as opposed to 26% of the 2 milligram. Now, this is not really an efficacy trial. This is really a safety trial. So the most important thing is that there were no new safety issues with this higher dose. And now there are 2 phase 3 trials, the Photon and the Pulsar. The Photon studies look at diabetic macular edema. It's comparing the standard dose versus the high dose in dosing intervals of Q12 weeks and Q16 weeks. And the same thing is happening in the Pulsar study, but for neovascular AMD. So this is really exciting because hopefully aflibercept will continue to be a very safe molecule. But now with the high dose aflibercept, we might be able to stretch these patients out to Q16 weeks. So basically quarterly injections instead of having to do every 2 months. And more of this data will hopefully be available by mid-2022. This is very exciting. It was just recently approved by the FDA in October 2021 for the treatment of neovascular AMD. This is a port delivery system of ranibizumab. So if you've heard of a port delivery system that's going to be approved for anti-VEGF therapy, this is what it is. It finally has a name. It's the Susvimo system. I hope I'm saying it right. It's relatively new, so I haven't really heard too many people actually pronounce this name. And what it is this implant here on the right. It's a permanent refillable reservoir that will passively diffuse ranibizumab into the vitreous cavity. And you can see it's actually a pretty big implant. So it's 8.4 millimeters long. And this most exterior portion of it is about 4.6 millimeters. So pretty big implant. The FDA used the Archway phase 3 study to get this approved. And what the study showed is that the visual outcomes between the Susvimo system and monthly ranibizumab was equivalent. But 98.6% of the Susvimo arm patients did not require rescue ranibizumab, meaning they were injection-free for that period of time. There were 248 patients within the Susvimo arm. The implant was refilled at week 24. The refill is in office. It's not done in the operating room. And then 167 patients received a monthly injection of ranibizumab. Unlike other anti-VEGF therapies, these patients were not treatment naive. They actually had, on average, 5 injections of ranibizumab before being recruited into the study. And that makes sense. You don't want to bring a patient into the operating room. You don't want to do a surgery on them for an implant that's going to release ranibizumab for at least 24 weeks without knowing that they're going to respond well to ranibizumab and they're not going to have an adverse reaction to the ranibizumab in medication itself. Visual acuity in both groups was pretty good, 20/32 on average. The initial VA for 80% of the group was 20/40 or better, 20% was 20/40, 20/200, and there was no patient worse than 20/200. And this is a summary of the kind of visual acuity data here. The black curve is the port delivery system, the Susvimo system, and the gray curve is the monthly ranibizumab injection group. And you can see at week 40 that they are essentially the same. But this is a surgical procedure. So the black curve, the Susvimo group, you can see they have a transient drop in visual acuity, which normalizes at around week 12. And that's probably due to a lot of different reasons, iritis, corneal issues. It might have been due to just some simple dryness in some of these patients after a treatment like this. But also some patients did have adverse reactions, which ended up healing by week 12. And then this is talking about anatomical outcomes. So again, black curve is Susvimo, gray curve is intravitreal ranibizumab monthly, and anatomically end up at about the same place. So an equal drying effect of both therapies. And again, I've been harping on the safety profile. Here is the difference at week 40 between these two. So Susvimo in the middle and ranibizumab monthly injections on the right. As a surgical procedure, this is something I think you would expect, but almost a quarter of the patients had iritis. This is probably something that I wouldn't have predicted, but patients also developed conjunctival bleb, about 9% of these patients. Hypotony in 6% of patients, and a vitreous hemorrhage in 5% of these patients. So you can see why there was a postoperative transient drop in visual acuity. There are quite a bit of adverse reactions occurring. And then most importantly, endophthalmitis, 1.7% in the Susvimo arm and 0.5% in the intravitreal ranibizumab arm. And you might think 0.5%, hey, that's higher than the 0.1% we were talking about before, but you have to remember this is only 167 patients. So even if you have 1 or 2 patients that get endophthalmitis, it will really skew your numbers compared to those meta-analyses of thousands of injections and thousands of patients. So the Susvimo system, the port delivery system, represents a treatment paradigm shift. Anti-VEGF therapy is no longer strictly in-office therapy. The way we are going to use this therapy is that patients who've had a previously documented good response to intravitreal ranibizumab, they'll be offered the Susvimo system. If they agree, they are taken to the OR, the implant is put in, and then they are monitored in the office. They will need a refill maybe every 24 weeks, possibly longer. We're still looking at some of that data, and we're getting more data coming out as well. But the important thing to remember is that the implant is in the operating room, but the refills are in office, and these patients can still receive additional intravitreal anti-VEGF therapy in office. So they can get an injection of ranibizumab in addition to the Susvimo system. They can get a FlipRecept, they can get bevacizumab, whatever it might be, if their disease state necessitates it. It's also going to be a little bit different than what we're used to in terms of anti-VEGF medication within the eye. Currently, we have this paradigm where we're doing this episodic bolus injection of anti-VEGF medication into the eye. So you get a lot of medication, and then that slowly goes away, and then you put a little bit more medication, and that goes away as well. Well, the Susvimo system is going to have long-lasting, continuous anti-VEGF therapy. So no more of these spikes. It's just a flat line of released anti-VEGF therapy, so sustained treatment. Now, is that a good thing? Is that a bad thing? At this point, I don't think we have enough data to know. I think there is some data out there, specifically in neovascular AMD, that continuous long-term anti-VEGF therapy or anti-VEGF suppression might not be the best thing, that maybe we should be titrating anti-VEGF therapy on a case-by-case basis. But since the Susvimo system has been approved, now we're going to have more and more data on that subject, and hopefully we'll figure out which one works better. And the other question is, who's going to perform this procedure? Will medical retina do it? Will surgical retina do it? Who are we going to be co-managing these patients with? Now, gene therapy, I think, is always an exciting topic, whether it's oncology, whether it's eye care. Anytime you hear gene therapy, I think everyone gets a little bit excited about it. And this is, again, a treatment paradigm shift. With gene therapy for anti-VEGF, you're going to have an injection of an adeno-associated virus vector into the eye, which will deliver a gene encoding for an anti-VEGF molecule. The injection could be intravitreal, subretinal, or suprachoroidal. The goal is that the single injection is going to provide long-lasting, continuous treatment as the retinal cells themselves start producing continuous anti-VEGF medication. So again, this is going to be different than our current episodic injection-based therapy. And the question again arises, is continuous long-term VEGF suppression a good thing? With this virus vector, there is a dose-dependent intraocular inflammatory response, meaning the more virus vector you inject, the more inflammation you get. So some of these therapies will require concurrent anti-inflammatory treatment, but we'll talk a little bit more about that with each therapy. ADVM-022 is an intravitreal injection of a virus vector which produces a FlipRecept. Again, limited information because the research trials are still going on. The OPTIC trial had 30 patients across 4 cohorts, and it studied ADVM-022 in patients with neovascular AMD who already had previous treatment. The 4 cohorts are right here. High dose vector, meaning more virus vector injected with prophylactic treatment of 13 days of oral pred, then low dose vector with 13 days of oral pred, then low dose vector with 6 weeks topical difluprednate, which is Durezol, and then high dose vector with 6 weeks topical difluprednate. And again, unlike our other studies, these patients are not treatment naive. Across the 4 cohorts, on average, patients had 25 to 38 anti-VEGF injections before being recruited into the study. And across all 4 cohorts, on average visual acuity was 20/50. Now I know this chart seems complicated, but let's break it down a little bit. This white line represents initiation of gene therapy treatment. Here on the side, each line represents a patient, and they're grouped by cohort. So this is cohort 1, cohort 2, 3, and 4. Each colored circle represents an injection of an anti-VEGF medication. Once a gene therapy was initiated, you can see there are a lot less colored circles to the right of it. In fact, you have a lot of these white empty circles. And these white empty circles represent time points where an injection was not necessary. So you can see a huge decrease in the amount of injections necessary to keep these patients at a good visual and anatomical outcome. In fact, in the high dose vector group, there was a 97% reduction in the amount of injections, and in the low dose vector group was 83% reduction. These cohorts were very small, so it's hard to generalize this data, but you can see that in cohort 3 and cohort 4, there was a significant drying effect, that the retina was much thinner. Overall, visual acuity was pretty stable over the whole time period, which is a good thing. No one lost vision, but patients tend not to also gain vision in neovascular AMD, especially if they've had it for quite a while. So that's something we've known for a long time already. Now, the safety profile, I've been harping on this. It was actually pretty good. These patients did have anterior and visual chamber inflammation, but it was treated with the oral or topical steroids. Now, if they weren't treated, who knows how bad the outcomes might have been. But with gene therapy, we know these patients need concurrent anti-inflammatory therapy. And as I mentioned, inflammation is dose dependent. More virus you inject, more inflammation you get. But luckily, there's no clinical or foreseen evidence of retinal, choroidal, vascular, or optic nerve head inflammation. So no hemorrhagic vasculitis or retinal arterial occlusive disease like we noticed in our Brolucizumab study patients. So this treatment paradigm is going to be a little bit different. It's going to be a lot less injections, hopefully, but there's going to be now this new treatable inflammation that we have to worry about. And for some patients, this might make sense. And we'll have to figure out who the patients that it makes sense for are, what if and when this gets approved. Another gene therapy is RGX-314. This is another virus vector, but it produces a molecule similar to ranibizumab. There are two trials, the Atmosphere trial and the Aviate trial. The Atmosphere trial was a subretinal delivery of this gene therapy. And this is specifically for patients with neovascular AMD. They had 42 patients that were already treated for neovascular AMD previously. On average, they had 30 injections before being recruited into the study. And the reason why they chose a subretinal delivery route is because that's an immune privileged space as compared to the vitreous. So therefore, you will get less inflammation. But to deliver that subretinal injection, you have to do a pars plana vitrectomy. And as we know, in phakic patients, if you do a pars plana vitrectomy, they almost always get a cataract within 5 to 7 years. And anytime you're injecting subretinally, there is also a risk of damage to the retina. And for these reasons, they also started the Aviate trial, which is a suprachoroidal delivery of RGX-314. And this is going to be an in-office procedure, so no surgery. And hopefully, without a pars plana vitrectomy, not many of these patients will get a cataract afterwards. This was their study. They did this dose escalation study where they were checking different doses. And as you can see, the higher the dose, the more of the anti-VEGF medication was found within the aqueous. And that's pretty intuitive. And then this is a mean change in amount of injections. For cohort 1 or 2, it didn't seem to really work so well, but 3, 4, and 5, you can see there's a pretty significant decrease in the amount of anti-VEGF injections necessary. In fact, in cohort 5, there's an 80% reduction in the number of injections necessary. For cohort 4 or 5, pretty good visual outcomes and a pretty good drying effect on OCT as well. So in all 42 subjects, the therapy was well tolerated. There were no drug-related serious adverse events, and there was less inflammation than you would expect from an intravitreal delivery. But is it less effective than intravitreal delivery? That's difficult to say. The reason why is because these studies, again, are very early. They're kind of very different approaches to how they do the study as well. So we don't know yet if intravitreal delivery is better than subretinal or even suprachoroidal delivery. That's something we'll find out hopefully in the next few years. Now moving on to some new molecules. Faricimab, this is something pretty exciting that's coming out because this is going to be an intravitreal injection of a molecule that has both anti-VEGF properties and anti-Ang2 properties. So Ang2 is angiopoietin 2 pathway, which is also involved in vascular permeability and neovascularization, just like the VEGF pathway. There are two studies, the TENAYA and the LUCERNE, which had over 1,300 patients that were treated with either faricimab or FlipRecept. Again, FlipRecept is kind of the gold standard, so a lot of these studies tend to compare to that medication. The faricimab arm was initially dosed 1 injection every 4 weeks times 4, then 1 injection every 8, 12, or 16 weeks, depending on disease activity. The FlipRecept group was a little bit simpler. It was 1 injection every 4 weeks times 3, then 1 injection every 8 weeks. At week 48, 80% of the patients in the faricimab arm had achieved a 12 or 16-week treatment interval, and 45% of those patients achieved a 16-week interval. And overall, faricimab was non-inferior as compared to FlipRecept in terms of visual outcomes, but far fewer injections in the faricimab group as compared to the aflibercept group. Here we have the TENAYA and LUCERNE studies. The purple curve is the aflibercept arm. The orange curve is the faricimab arm, and this is looking at visual outcomes. And as you can see, at week 48, the visual outcomes are essentially the same in both studies. And then we have another new molecule. We have the KSI 301 molecule. This is an intravitreal injection of a novel molecule that has anti-VEGF activity as well, kind of like faricimab or Brolucizumab, FlipRecept, but it's using kind of a different concept to achieve that anti-VEGF activity. What it is, it's a very large molecule with high affinity for VEGF, which increases the tissue availability of this medication. So it hangs around in the eye for a long time is basically what it is. The half-life is 10 to 12 days of KSI 301 as compared to 3 to 4 days of ranibizumab. And you might think, hey, if it's hanging out for a long time within the eye, it's probably going to hang out for a long time in the body, and then you have higher risk for systemic side effects. Well, luckily, this molecule actually clears very quickly once it leaves the eye. So hopefully there won't be many systemic adverse events with KSI 301. Like a lot of these other treatments, it's very early on in the research phases. In the phase 1b trials, they had patients treated for neovascular AMD, diabetic macular edema, and retinal venous occlusive disease with macular edema. They compared 2 doses, the 2.5 milligram group and a 5 milligram group. And it was a 1 injection every 4 weeks times 3. And then patients were retreated as per the specific protocol for the disease and disease activity. And so far, safety profile seems to be similar to our current standard of care anti-VEGF agents, meaning our aflibercept, our bevacizumab, and ranibizumab. So that's a good thing. So even though this molecule hangs around the eye for a long time, it's still very safe. And this is just the 3 different disease states: wet AMD, neovascular AMD, diabetic macular edema, and then the retinal venous occlusive disease with macular edema. Small cohorts, 15 15 and 25 neovascular AMD. And we can see the visual outcomes are quite good. They are improving in all three groups, and the anatomical outcomes on OCT are quite good as well, with a significant drying effect in all three disease states. But the major thing is that the treatment burden is much less. In the wet AMD cohort, 68% of patients achieved a 6-month treatment interval at least once during the whole study, meaning that they were able to achieve a 6-month period where they required no injections. 45% of patients in the diabetic macular edema group did not require a single retreatment. And in the retinal vein occlusive disease group, 71% of patients achieved 4-month or longer treatment interval at least once during follow-up. So that's tremendous. That's a significant decrease in treatment burden for patients while having good visual and anatomical outcomes. So in conclusion, there are new anti-VEGF treatments coming. Some are already here. And with these new therapies, there are new treatment paradigms. Now, will it really shift the majority of our anti-VEGF treatment paradigms? Hard to say, because we don't know how successful these treatments will be. But there's more and more coming out every year. So I do think at some point our paradigms will change, just like all things in healthcare change. So it's always important to keep an eye on what's coming out in the future. But you always have to remember that the goal is a safe treatment with hopefully better efficacy than our current treatments, and hopefully a smaller treatment burden for our patients. As we know, patients don't like getting injections into their eyes, so if they can do it maybe once every 6 months, maybe even once a year, or maybe even once a lifetime in a safe and effective manner, I think patients will like it, retinal specialists will like it, and optometrists will like it, because we won't have to keep convincing our patients like, hey, you need these injections, don't be scared of injections, they are saving your vision. So with that, thank you all for spending some time with us today, and I'm happy to answer some questions now. And this is my email if you prefer to email me questions, or you want to just talk shop in general about this topic, or you want any of these slides, happy to send them your way. And with that, let's go over some questions. Thank you.
Hi, Dan. Welcome to the Q&A. That was such a great lecture on updates on anti-VEGF agents. I think it's so exciting what's coming down the road. We had some really, really great questions in the chat, so I'm going to go through some of those with you. The first one that we'll jump into is, what are the clinical indications that you think about between treating patients with injections versus laser for diabetic macular edema?
So for diabetic macular edema specifically, because we're talking about the fovea, the macula here, I think almost everybody is going to jump to anti-VEGF injections, because you don't want to leave laser scars, you don't want to leave the vision worse than when you started sometimes, especially if it's very mild macular edema. It responds very well to anti-VEGF injections.
Yeah, I definitely agree with that. In our practice, I think the classification from DME, we used to do CSME, now we're doing obviously DME. I think that was really helpful, because if it is a really focal spot, then I do think sometimes laser can be helpful. But, often, the injections are really, really the way to go. Let's jump over and think about still our diabetics, but what about treating them earlier? Tell me your thoughts and kind of where you think, or how in your practice are patients being treated based on the panorama and protocol W?
Yeah, so based on those studies, within a 2-year period, we know that the visions can be basically the same, whether you treat them prophylactically or you treat them on a kind of as needed basis. But again, like I mentioned in the lecture, that patients in the real world tend to have worse outcomes than in our big research studies, and they tend not to follow up as often. So if you don't monitor them as often, you won't catch the disease earlier. And we all know that the earlier you treat disease, the better outcomes you have. So myself and with the medical retina doc that I work with, we kind of came together on that some severe NPDR patients we are treating, especially the ones with a high A1C, the ones that are trending up in A1C instead of trending down. Those we're definitely offering treatment at least, because the way we think about it, we're going to see them back pretty often anyway. So you might as well be on a, kind of our Avastin day or our Eylea day anyway, because
yeah, that's great. I really love your recommendation for those ones that are trending up, the ones you're kind of worried about, that they're not as controlled. That's really, really great piece of advice there. Awesome. What about the port delivery system? I mean, that was just approved really, like in October. So obviously I don't think most people are hearing about it really from an FDA perspective, very, very recently. How do you see this fitting into your practice? What type of patients do you think would be good for this port delivery system?
So I think, it's a great question, and it's hard to say exactly how much penetration this innovation will have in our kind of real world now. I personally have heard everything from, the research studies. I've talked to a doc or two who's kind of peripherally involved with these studies, but I haven't co-managed these patients personally. But I think the type of patient who this would be good for is someone who's had great results with ranibizumab injections, but then just never really dries out. Like maybe you keep extending, and then they keep getting more subretinal fluid, and then you treat them and they kind of go back to normal. So maybe you offer them a port delivery system and they stay dry for a long time and without requiring multiple injections per year. But again, it's really going to depend on how we get that real world data once a lot more people are using the system.
Yeah, I think it's really exciting. And I'm sure, insurance coverage and many other things are going to be another element of confusion once we get going with it. But I do think also, great potential for other applications. So this is really a step in the right direction for our patients. Let's talk just briefly about gene therapy and treatment modalities for, using anti-VEGF agents there. Again, who do you think are going to be the right patients for this? I think it's so exciting to be thinking about gene therapy, but how do you see this impacting clinical care?
So that's going to be an interesting paradigm shift also if it's successful. So the current studies are still relatively early on in the research phases, but you can imagine a patient who's responded well to a FlipRecept or ranibizumab in the past, then you might want to offer them this gene therapy, so this vector that makes the retinal cells produce the medication on its own. But patients who've had inflammation, whether it's uveitis in the past or anything even as simple as like a really prolonged post-cataract inflammation, I'd probably be a little weary of using it in those patients because we know the gene therapy that patients are going to have a lot more inflammation than just doing regular, ranibizumab or aflibercept injections in office.
Yeah, that's really, really great. Well, thank you so much, Dan, for joining us for the Q&A today. I think that really addressed everybody's questions that came through. Just a couple notes about the conference. I want to make sure that everybody takes a second and clicks on the conference bag link that's at the very top of the page. There's a couple things that are really important in here. One is your free download of the 2021 optometrist report from Eyes on Eye Care. But the really, really important one is that there's a link that you can click, and Eyes on Eye Care is donating $1 for every click to Foundation Fighting Blindness on your behalf. So please go up there. There are over 10,000 people registered for this meeting. So there should be over 10,000 clicks on there, and there are not right now. So go up there and click. It's really easy. Our next session is going to be in a little bit about orthokeratology at 12:10 Pacific time or 3:10 on the East Coast if you're with me. But in the meantime, head over to the implementation track. There's some really, really great stuff going on over there. And we also have some exclusive raffle codes that you can grab if you are attending the implementation track.